Hi, my name is Sean Collins. Some of you probably know me if you work for the Home Health VNA and you've attended some of the sessions that I've been part of. I am going to be doing a series of short tutorials. I think I may have discussed this at one of the meetings. And these tutorials are going to introduce you to the overall process of using the cardiopulmonary care path by which patients with chronic heart failure and chronic obstructive lung disease can be considered based upon two major factors: whether or not they seem to have a disease-specific impairment and whether their primary limiting impairments tend to be reversible or not. The overall tutorials will end up being quite repetitive, but I think because of the slow, repetitive pace associated with these short tutorials, I believe that if the concepts haven't become part of the way you think yet explicitly, then they could from following along with these tutorials. So the way it's going to work, and this is tutorial 0 because it's not really a tutorial, it's just an overall introduction. The way it will work is that they will be anywhere from 7 to 10. It depends on whether some of these 7 that I'm planning need to become 2 for the sake of keeping the files at a reasonable length. I expect them to be 8 to 12 minutes in length. They will be best viewed in order, although that is not completely necessary. There'll be definitely an informal presentation. So I'm sitting here in front of my iPad essentially and talking to it. And I can actually write while I'm talking, and it'll show up here and for you to see. So some of the slides will have absolutely nothing on them initially, and I will fill it up with words and drawings to the best of my ability to help make a concept more clear. At least I have personally found that watching tutorials that include interaction like that with the speaker, it keeps things slower, and it helps the person watching sort of follow along a little bit more clearly. A major benefit is that you can watch as quickly. You can skip through things if you feel like you already understand the concept, or if you don't understand a concept, you can repeat it as often as you like, and hopefully by repeating it you would understand it more. If not, then you could probably it would help you to understand it enough that you could formulate a question to one of your colleagues, or you could shoot me an email with that question. But I would hope that before you would ask questions, you would watch something a couple of times and at least generate enough of an understanding that you would know really what you are asking. So the overall goal of the tutorials is to provide a background explanation and understanding for the adoption of the quadrant classification for making clinical decisions in patients with cardiopulmonary disease and associated activity limitations. And we'll get more into that, what this means in the tutorials, but essentially we're talking about activity limitations because of poor endurance. After watching the tutorials and taking the self-assessments if you choose, and completing the in-services that are going to be provided by the educators at the Home Health VNA on how to do examinations, you will be better prepared to attend the face-to-face education session that we're going to do after the tutorials, to go through case presentations and discuss how the quadrants can be useful in goal setting and intervention planning. So the tutorials, what they do is they attempt to explain the heuristics associated with using the quadrant categorization in patients with chronic cardiopulmonary disease. A heuristic is an experience-based technique for problem-solving, learning, and discovery that give a solution which is not guaranteed to be optimal, where an exhaustive search is impractical. Heuristic methods are used to speed up the process of finding a satisfactory solution via mental shortcuts to ease the cognitive load of making a decision. So one thing that's clear in clinical practice is that exhaustive searches are in fact impractical. There is no way for you to possibly understand every single physiological, pathophysiological aspect of your patient in making your decisions. You need to quickly find the most important aspects, and that's a heuristic. There are two components to the system. First component are the quadrants, and the second component is the algorithm. So I'm going to talk about both of those briefly now, just as a general introduction. And you probably remember quite a lot of this, or at least being introduced to it. The quadrants essentially are a 2x2, it's a 2x2 diagram, and it allows us to take a patient and basically pose two questions. Do they have a disease specific impairment causing their activity limitation? So causing their activity limitation. And we can say that they either do or they don't. For the sake of the quadrants, you do need to say whether they do or they don't. It is the only thing I'm certain of is that you will not be certain of whether they do or they don't. You are making a hypothesis about whether they do or they don't based upon the evidence presented to you from your examination, and that will be a big part of these tutorials, is what that evidence looks like to lead you to believe yes or no. On the other axis of the quadrants, you consider whether or not the impairment, whatever the primary impairment is, whether the impairment is reversible or irreversible. So if somebody has a disease-specific impairment and it's irreversible, well, this is a very different situation than having a non-disease specific impairment that is reversible. I mean, right off the bat, the goals, the expectation for improving endurance is much higher in this individual. Higher expectation, greater expectations for improving endurance. The time that they can sustain a particular amount of work, or increasing the amount of work that they can sustain for a particular amount of time. So this is one of those aspects that will be extremely repetitive during the process of these tutorials. The algorithm, all an algorithm really is a decision tree, and they have branch points. So, we've got a condition, and we know that there's a few options that come off that condition. For the algorithm that we're going to be using, the conditions, the branch points are always yes or no, that this condition is met. And then there's another consideration for either the yes or the no. And then there's another branch point And it's a way of modeling thinking. It's a way of trying to take the thought process that individuals utilize in coming to a conclusion and coming to a decision and trying to give it some framework. They are a guide, not an absolute prescription. All right, so the algorithm that we're going to be using, and this is the full algorithm, is, and you've seen this before, starts with whether or not the patient is stable at rest, and we will have a session discussing that and what the signs and symptoms and the ways of thinking about it. And if they are stable at rest, then you proceed to activity assessment. If they're not stable at rest, then you need to obviously consider the options for intervention at that point. And you intervene, and then you assess again. And then you could be in this loop right here until such time that the patient is stable at rest. But all this is really saying is that you don't proceed to activity until the patient is stable at rest. Once it's established that they're stable at rest, then we get into the phase where we're considering movement, activity, and you must assess the person during activity. And you're trying to figure out whether there's a function, whether function is limited due to endurance. And if it's not the case that function is limited due to endurance, then this isn't the pathway. This is not this quadrant system isn't related, at least not explicitly, to other conditions. That's not the focus of the tutorial. Now, one could generalize this process and come up with one where the quadrants are specifically designed to assess balance or other sorts of function limiting impairments, but this one here is specifically for endurance. Is endurance limited due to disease-specific impairments? This is a big question because people without diseases can have normal reductions, limitations in endurance. So the question about whether the patient you have in front of you has a disease-specific impairment as the root cause of their endurance limitation, their activity limitation, is really important. So we'll have some tutorials on that question. If they do, then are they reversible? And we answer that question based upon a consideration of whether or not their pathological process is reversible. And if they do not have a disease-specific impairment, then we have to consider what the impairment is and the pathological process of that impairment, or the non-pathological process associated with that impairment. How adaptable is it? So that's the consideration for this side. And we end up having our 4 quadrants. We have disease-specific impairment with reversibility. We have disease-specific impairment without reversibility, with irreversibility. We have non-disease-specific impairment with reversibility, and we have non-disease-specific impairment with irreversibility. So the tutorials, as I said, there are 7 planned. They might end up, some of them might take longer than what one video can allow, given the size limitations for the videos. So they might end up carrying over, but they will still be titled and the topic will still follow. Monitoring resting stability will be the first one. Monitoring activity stability will be the second one. And this is an introduction, because the rest of it is related to monitoring activity stability. Normal cardiopulmonary response to activity will be covered. Then we will discuss non-disease specific, what a cardiopulmonary response looks like for a non-disease specific impairment limiting endurance. Then we will look at heart failure and the cardiopulmonary response associated with the disease-specific impairment of heart failure. Then we will look at COPD and the cardiopulmonary response of a disease-specific because of COPD. And then we will discuss impairment, adaptation, and reversibility, sort of the final set of questions, and end with a quick discussion on where the quadrants are. But we will really discuss what it means and what you do with patients in the various quadrants when we do our face-to-face sessions after the tutorials are completed. Thank you for listening. I look forward to continuing to be part of this process with you all through these tutorials and eventually with a face-to-face session.